Thank you very much. I always wonder about the applause before the talk. What if the talk isn't great? Well, there's not much you can do after that. So thank you. Thank you. Yes. And sometimes we assume the applause is also for the person who spoke before. So maybe that was all for Marina. Um, yeah, so today we're gonna approach EDI from a different perspective. We'll look at some of the an overview of inequalities in health, some of the frameworks that exist, some problems and some potential solutions, and then we'll look at the consequences of these inequalities in health, and then I'll offer some practical guidelines. So there's several things we can talk about, but I'll focus on some of the things which are more proximal to the kind of work that we do. So in terms of definitions, we're talking about EDI. So EDI is essentially equity, diversity, inclusion. Equity is removal of systematic barriers. That's just it. Remove those barriers, let everybody have the same thing. And diversity is acknowledging the variety of unique dimensions that exist among us as humans. And inclusion is just ensuring that all individuals are valued and respected with their different contributions. I'm just putting this up there so that we have a baseline, but obviously everybody has some experience with EDI and has some understanding of what these concepts mean. So I am sure everybody has seen these pictures 1,000 times and everybody has a sense of what they're supposed to convey. But I always bring them up because some of them are great and some of them are not great. The idea is to simplify the concept that equity is not the same as equality, right? But some of the pictures have concerns. And each time I give this presentation, I get feedback from the audience, which makes me rethink how I use these figures. So if you look at the top one, I particularly like it because where it says reality, it demonstrates one key thing which we forget about EDI, that some people start with less than nothing. The person who is in the ground is actually starting off with less than nothing. They don't just have nothing. They're not starting at the ground level, right? And then the stuff in the middle, I don't like as much, but the stuff on the other side, which describes liberation, is even better because it suggests that instead of taking from one person and giving to the other, just remove the systemic barriers, right? And that's what EDI is about. And that's why I don't particularly like the two cells in the middle because it looks like you're taking from one person and giving to the other. And that is not what equity is about, right? It's about removing the barriers. It's not about taking from one person and giving to the other. And I put in the other examples just because they're fun to look at. I particularly like the guy, the huge guy on the tiny bicycle, kind of reminds me of myself because my bicycle is really small. And that's just why it's there. There's nothing to talk about. So in terms of frameworks, there is Progress Plus, the first one I'll talk about. It's really nice. Many people like it because it's straightforward. It describes issues of EDI as variables. And these are all variables that we can capture if they are relevant to our research. It includes place of residence, race, ethnicity, culture, language, occupation, gender, sex, religion, education, socioeconomic status, social capital, and then they have plus, which is the beauty of this, because plus is anything else which may come up as a source of inequity. So this framework is really, really nice and encompassing. The next one comes out of the UK from a group called Trial Forge, and it's called Include Ethnicity. It is designed specifically for ethnicity, and it is structured so that you can ask yourself 4 questions about your research. And these are questions that we ask ourselves, but we sort of get lost in the details. Who is your research for? If it's for everybody, include everybody. It's that simple. And when I say I approach EDI from a different perspective, my perspective is a methodological perspective. The principle is as follows. If the people in your study do not match the people to whom you want to apply the evidence to, it is bad science, right? It's not an advocacy thing. I'm not saying get more women in your study. I'm not saying get more Black people in your study. I'm just telling you this is selection bias and it's bad science, right? So from a methodological perspective, the goal is to do better science and not so much to, cater to individual needs and priorities. There is another framework which everybody here is probably familiar with, but it focuses only on sex and gender. It's also a good framework if that is the focus of your research. It elaborates on how to incorporate sex and gender in research and also how to report sex and gender in research. And then there's this one which I have been battling with for close to 3 years now. There is no way of finding a clearer figure than this. Like it's impossible to see, but it's a great framework. It really includes everything. It includes policies, it includes your outcomes, it includes how people react to stress, it includes biology and a bunch of different things and how all of these impact your health outcomes. So it's a great framework, and hopefully by this time next year, I will just recreate it on my own, or I'll find a student to do it. But we need something that is clearer than this, right? But it's a great framework. It's very, very, very holistic. So in terms of the big picture, EDI in research is not just about going out there and trying to recruit people. That is just one small part of it, right? We can talk about the research funding. What kind of research is funded? Where is the research money coming from? And I give this example when I'm talking about global research. I trained as a researcher in Cameroon, and the research funding we have is for global fund priorities, which means either I will be an HIV researcher, which I think I am, a malaria researcher, a TB researcher, or something else, right? But guess what's killing people in Africa? It's road traffic accidents, it's non-communicable diseases, it's other things which nobody is funding, right? So this is where the inequities start entering the research agenda, because you can only do research on what you have funding for, right? So that's one thing we can talk about. And then there's also research leadership. Who is the leader of the research? We'll talk about that in detail, so I'll skip it. The two things we will not talk about, background literature and knowledge mobilization. So in terms of knowledge mobilization, there's a lot to be said for how the research is disseminated to the right audience so that it has the impact that it should have. And the way we disseminate research, the way we interpret research, the way we present research can also lead to certain inequities. In terms of background literature, the simple fact, men scientists do not cite their female colleagues. This is an issue which might seem trivial, but if you don't cite the research in the background of your paper, it doesn't influence the design of the study, which is problematic, which suggests that we are not going to be addressing the issues that affect women. We are not going to be addressing the issues that affect ethnic minorities because we are not citing their research, right? We cite a selected piece of the research which fits our narrative, and therefore we are already introducing inequities just from a big picture perspective. So that's a concern. But we're going to talk about research leadership, research staff, research participants, and research data, because those are the things which we could probably manage a little bit better in this room. So research leadership, there is a gender gap in leadership of clinical trials, right? This is a clinical trials network, and what we're seeing is there's always more men leading research, which is a problem. If you look at funding for clinical research in the US, and you look at the lines, the line at the top is white funding research, and all the other colors at the bottom are for all other ethnic minorities, right? This is a problem, right? This is evidence indicating that there is a problem in how research is funded. And this just means that the evidence base that we're working with is going to be skewed, irrespective of how you conduct the study. And here are some examples that show that there's a huge underrepresentation in women in cardiovascular disease trials, right? So pick up any cardiovascular disease trial, and you will find that women are underrepresented. And the reason, at least one of the reasons why women are underrepresented, is because there is no leadership in these trials. So people participate in trials led by people who are like them. This is true for gender, this is true for ethnicity, and this is true for many other conditions. And then there's also another study that showed the representation of Black participants in emergency room trials in North America, so US and Canada. And there's also a huge underrepresentation. And again, it is tied to leadership. So each time the PI is Black, more Black people tend to be enrolled, right? So we can address some of the EDI issues simply by thinking creatively about leadership of trials. This is a study which I am currently still working on. So I have a database called Cascade, which includes all the clinical trials where the outcome is initiation of treatment, adherence to medication, and retention in care. And I looked at differences in female leadership over time. And you can see female leadership in clinical trials is increasing over time, and we defined it in different ways. So we have instances where both the first author and second and last author are female, where only the first author is female, where only the last author is female, and also when either the first or the last author is female. And you can see that this has been increasing over time, but previously it's been abysmal, right? So there is hope, at least with HIV. And another comment I want to make about this presentation is that whenever I am doing this elsewhere and I have to give examples of good practices, I always talk about the CTN. So compared to most other groups, we are doing much better, right? But I think there's still some more work we can do. So the solution to this will actually be to collect and use the data, right? If people don't see the research on these disparities, they won't know that the disparities exist. And that's part of the problem. So we should collect this data, we should document the data, right? All the roles I have as an EDI champion, the only thing I ask for is the data. Show me the numbers, show me the recruitment numbers, show me the people who applied for the position, and I want to compare that to the people who actually got the position. And then I can tell you if there is unconscious bias somewhere in the middle, right? And yes, we can diversify our leadership based on our target population. This is important. People need to see themselves in the research that they're participating in. And obviously, it's not as easy as that because it's tied to career achievement. So if we're getting more male PIs, it might be because there are more male full professors and in higher positions, right? So career achievement is also a big issue, which has to be addressed parallel to leadership in clinical trials. Okay, so let's talk about the research staff. We all have our favorite recruiters and study coordinators and people who make the trial really work, the machinery of the study. But they are the face of the study, right? And what that face represents influences how people participate in the study, right? I have had very young people trying to recruit senior people, and it doesn't work as well, right? One of the most successful studies I've been part of is the CHAP trial, where we got seniors to enroll seniors, and it worked very well, right? The senior person is happy to have a conversation with another senior person, and they can both sit down and talk at their own pace at the same level of energy, and it'll improve recruitment in the study, right? So research staff is not sufficiently diverse. They could be more diverse than they currently are. Okay, in terms of solutions for this, we need to adopt appropriate hiring practices. And there is value in planning the team composition and communicating the job opportunity appropriately so that you get the right people who fit the job description and who in some ways match the demographics that you're planning to include in your study, right? And this influences your recruitment processes, and the value of peers cannot be understated, right? For most studies, peer recruitment always enhances the recruitment. So in terms of participants, the facts, the information that we know, many groups are underrepresented. So this is not a comprehensive list, but there's women, there's racial and ethnic minorities, people of low socioeconomic status, non-English speakers, and many other groups, right? And this introduces selection bias, limits the generalizability of the research we are conducting, and it also aggravates inequities because if you're not doing research on them and then you don't have solutions for them, and that creates a higher gap. So the example I have here is showing global data from orthopedic trials. And these are main landmark trials that are used to influence evidence all over the world. The blue is the white people in the trial, and the other colors are the other ethnic minorities, right? So you can see how skewed the evidence is, right? And this is evidence that influences everybody in the world, that is applied everywhere, but the research is conducted on a small subgroup of humans, which is concerning to say the least. Here is another example of some work I did for the WHO. We're looking at the prevalence of pre-treatment HIV drug resistance in key populations, defined as men who have sex with men, commercial sex workers, people who were incarcerated, people who use injection drugs, and transgender people. And we found the one study reporting on pre-treatment drug resistance in transgender people. And that was problematic. It wasn't even one study on transgender people. It was one study that included data on transgender people, right? And this is problematic in several different ways because when we break it down by region of the world, right? Each region has their own thing which they think is fancy or not fancy, in part due to criminalization of HIV. So in Africa, almost no studies on MSM. We know there are MSM in Africa. So if there are no studies, there's a different problem, right? In the Mediterranean region, no studies on sex workers. We're like, yeah, they have to be sex workers in the Mediterranean. It doesn't make any sense. There's sex workers anywhere. It's the oldest profession, even described in the Bible. They have to be there, right? And in other regions, there were those discrepancies. One of the most concerning one, and Nadine will probably like this, was information on people who are incarcerated. Like everybody has prisons. There are countries where they have huge proportions of the people in prisons, and yet we can't tell what the incidence of drug resistance is in those places. So that was also concerning, right? So there's more we can do to make things different. So what's the solution for this? I'm pretty sure you've heard all of this before, but I will repeat it again just for emphasis. Budget for enhanced recruitment, right? Use community engagement, education, multimodal communication. So audio, video, translated stuff, all of that, do it. Every time I put this up, people say, yeah, we don't have the money. My pushback is, it's not your money. Put it in the budget, right? It's not coming out of your pocket. It's coming out of your budget. So add it to the budget and say, we need this extra amount because we want to do this special kind of recruitment, right? Create community advisory boards. They work well. I usually talk about the CAC when I'm giving this example. Review your eligibility criteria. The worst thing you can have in the eligibility criteria of a bilingual country is that you're including only people who speak English. It is terrible, right? It's just a bad idea. Whenever I see it, I always push back. Likewise, for systematic reviews, people who include only English language papers, it just doesn't make any sense. I guarantee you, in this room, we have at least people who speak at least 7 different languages. In every room I have tried the experiment, I have found people who speak 7 different languages. We have English, we have French, we have Arabic, we have Mandarin, who wants to offer a language which I haven't mentioned? We have Spanish. Do we have Portuguese? We have Arabic. Do we have Punjabi? Do we have Polish? German, Greek, Italian, Urdu, Sinhalese. So in every room in Canada, there are always at least 7 languages. And there's nobody here who would say no to translating your abstract for you or just reviewing the abstract and saying, yes, this study is eligible or it's not. So we can do better. And then the next thing, which is part of what that first figure shows, is removing the barriers to participation, right? Remove those barriers so people can actually participate. Contribute to parking fees, do flexible times, childcare, transportation. I have actually heard patients say this. Doctors work 9 to 5 and they book appointment 9 to 5. But guess who else is working 9 to 5? The patients. Everybody else is doing something 9 to 5, right? And the irony of research is when people are sick, they come to the hospital, they need us, right? But when it is research, they don't need us. They are not sick. We need their data. But somehow we make them come to the hospital. In a just world, we would go to their homes and request data from there, right? So we should be a little bit more humble in terms of what we're asking for our participants, from our participants. Obviously, if you have the participants in your study, you should collect the equity relevant data. Emphasis on equity relevant. I'm not saying you should collect religion, place of birth, occupation, and all that stuff. You should collect those which are relevant to your study, those which could influence the outcomes of your study, and then compare it to your target population, right? So who is supposed to be in my study? Should the people in my study mimic the population of Canada, the population of Halifax? Always make that comparison so that you're sure that you're not inadvertently including and excluding anybody. And then I also encourage the use of pilot studies to identify recruitment issues, if there are any. So here is some work I did for the Ontario Ontario Hospital Association Anti-Racism Task Force, and we identified several different solutions reported in the literature on how to sort of increase diversity in the participant pool that we have in clinical trials. And the first thing was improve recruitment practices, right? And there's a whole list of other things which I wouldn't go through. Some are more exciting than others, including like changing research design. So how can we better design research so that our recruitment is better, right? If we think from the design stage in terms of what the intervention is, where we are recruiting, when we are recruiting, how we are disseminating information about the study, we could make an important difference. So the next thing I'll talk about is the data, right? Most of the time, the data on inequities is not captured in studies, right? So we need to have all of that data on sex, gender, ethnicity, place of residence, occupation. Each time these things can influence people's outcomes. So I used to have a slide which I took out, which shows mental health compared to type of contract. And the type of contracts were no fixed contract, part-time employment, full-time employment. And as you go down that gradient, mental health also goes down, right? So you can be doing a study and you have quality of life outcomes and mental health outcomes, stress and stigma and all that stuff, but you don't know what kind of employment these people have. And this is what is actually influencing their outcomes in your study, right? So that might be relevant for some studies. So sometimes the data is also collected poorly, like the categories don't make sense, or it's collected in groups that just can be disaggregated. And even when it's collected, it has to be analyzed and interpreted correctly. Emphasis on the interpretation. I'll talk about that later. And the truth is, not all studies are designed to answer questions of equity. So while we want EDI, you may be starting off with a phase 1, phase 2 study where EDI does not necessarily have to be the focus. But you are encouraged to clarify why it is not the focus at this stage of the study. What will be the solution? First of all, if you're analyzing the data, it's impossible if it's not collected, right? But if it's collected, there are several things you can do, including disaggregated analysis, stratified analysis, adjusted analysis, formal subgroup analysis with interaction terms, and then you can also do intersectionality analysis, which looks something like this. So the idea is you're trying to understand how the mediator variables work, and you can use several different aspects. So for example, if you're looking at the impact of ethnicity and gender, and then you sort of structure your data into white men, black men, white women, black women, and then you sort of have a number of groups, and then you can see how that interacts with the intervention and how your outcomes are different across those strata, right? Won't go into much detail on that, but that's something that can be done. One other piece is the reporting, right? A lot of the times people do good work, but they don't report appropriately. But there are guidelines for reporting of EDI data, especially ethnicity and sex and gender as well. And there's papers, there's the Construct Equity, which clearly outlines how equity data should be reported in clinical trials. We recommend that the categories and groupings should be meaningful and also not offensive, right? If you look at the different ones I have here, North America uses BIPOC, the UK uses BAME. What I'm pushing back against is non-white. It is problematic and very uninformative, right? Think about me saying, I want to sell you a device, an electronic device, but it is not a cell phone. It could be a laptop, it could be a tablet, it could be my clicker, it could be a smartwatch, it could be everything except a cell phone, right? So that category, whenever I see it in the paper, I always push back and say, what do you mean? At the very least, tell us what's included in that category. Don't just throw it out there and walk away, right? It is not very useful. Again, with your data compared to the target population, and the key part where I put an asterisk there is discussing the implications, right? So if you're saying, well, HIV drug resistance is higher in people in prisons, you can't just drop that and leave. You have to follow it up with a conversation about why you think it is that way, right? It's our responsibility as researchers not to drop information that can be misinterpreted without proposing an accurate interpretation, right? And then there's also issues around data sharing and data ownership, which enhance equity, right? If there's ownership of data, then the people who own the data should be involved in the interpretation of the data and how the data is disseminated and how it is used. And of course, people will tell me, well, the manuscript only allows for 4,000 words. So I say, put it in the appendices. People who are interested will find it and they'll read it. Put it in the appendices. Everything is electronic now. It's not back in the day when we had hard copy printed out journals, right? Everything is online now. And to the best of my knowledge, the internet has infinite space. So put it in there. Somebody will find it. And then there's guidance, right? So CMAJ has published new guidance on how to report race and ethnicity in research. JAMA had also published something like that. And then there's the sex and gender analysis as well tool. Okay, so the next thing is the consequences. We don't include the right people in research, we don't have the right information about them, and then we do bad research, and it harms people, right? Everybody experienced the issues of pulse oximetry in people with darker skin. They weren't getting oxygen during the pandemic because the pulse oximetry wasn't giving accurate readings, right? And then there are also issues with assumptions about pain thresholds in people with darker skins. And there's evidence showing that Black kids don't receive enough painkillers after appendectomies. Absolutely bizarre and absolutely wrong. But that's what the evidence says. You measure it and you see that it's not done like it should, right? And CIHR has also noted that, not including EDI in your research leads to poor quality research, as I mentioned earlier. It perpetuates systemic barriers, provides decision makers with information which could potentially harm other groups, tends to favor some stakeholders over the others, creates skewed data, and it could also generate harmful outcomes for some groups. So practically, you have to ask yourself who your target population includes, how you can design your study to include them, and how you can design your study to not aggravate this disadvantage. So generally speaking, there are two scenarios in which this can happen. The first is a mixed study where you have everybody in the study, right? But then if you have identified an issue of inequity in a particular group, instead of enrolling everybody and saying, I'm trying to meet a quota of ethnic minorities or Black people or men who have sex with men, just do the study in the population where you have the concern, right? If there's a concern on cardiac issues in women with HIV, do the study on women in HIV. Don't do a study on everybody and then try to find if there's any data on women, right? You can focus your data on that particular group. And then in some instances, the equity relevant issue is the intervention, right? It could be that you've identified that there are issues with education and knowledge, and therefore your intervention is introducing education and knowledge. So here are some examples. For example, a trial in Hispanics, trial in people with low socioeconomic status, like that one as well. And this one here is an interesting one. Social capital can be introduced as an intervention in a trial. Just an example. So best practices, determine the relevance of equity in your research question, review the composition of your team, budget for all this, create a community advisory board, review eligibility criteria, accommodate translation if needed, remove barriers to participation, collect the data. That's how you can prove that you did the good job. Compare your sample to the target population, use pilot studies if needed. Peer recruiters always make a difference. If you have the opportunity to use peer recruiters, use peer recruiters. And then there's the issue of return of results, right? You have the data, you've done the study, return the results back to the communities where it came from. That's the best thing you can do for them. So I'm almost done. It is more resource intensive to do good EDI research. I'm not gonna color code it. It's more research intensive, and the added value is not obvious when you're doing it, but it's more rewarding. The research is always better. It's more generalizable, and there's more equity because you balance the risk and benefits of research, right? And it's also more fair because the benefits and the burden of research are shared. If you collect the data, even if it's on 5 people, it can be used in a meta-analysis in the future. Somebody else might pull the disaggregated data from several studies and use it. So there's no harm in collecting it and keeping it in an appendix somewhere, right? And it also helps to highlight signals for future research, even if it's just in a few people. And finally, it helps build patients' trust and confidence in research. So take-home message, beware of the inequities that could affect the internal or external validity of your study. Try not to aggravate these inequities in your design, conduct, analysis, and reporting of your study. And then also collect the data on the equity relevant characteristics. Thank you.